Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the Robert Wood Johnson Foundation, on addressing social determinants of health, connecting people with complex needs to community resources. This webinar is the second in a two-part series that explores how providers are building on existing complex care programs to extend care beyond the walls of the clinical setting and into the communities where people live, work, and play. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following each presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Caitlin Thomas-Henkel, Senior Program Officer at the Center for Healthcare Strategies.
Thanks so much, Travis. Welcome, everyone, to today's webinar. We're thrilled to have you as part of our second of a two-part webinar series. So there's wide recognition that addressing social determinants of health is important for improving health and reducing disparities. We're pleased to share insights and strategies from two providers who are developing innovative ways to address social determinants among their patient populations by bridging the gap between traditional healthcare systems and community-based organizations. First, I'd like to do a quick agenda review. We have two terrific providers who are presenting today from AccessHealth Spartanburg in South Carolina, followed by a Q&A portion. Then we'll turn to Petaluma Health Center in Petaluma, California, followed up by some reflections from Derek D'Elia, our evaluator from MedStar Health Research. And then we'll close with a Q&A portion. So a little bit about the Center for Healthcare Strategies. CHCS is a nonprofit health policy resource center dedicated to advancing access and improving the health of low-income Americans. We have three main streams of work: advancing delivery and payment reform, enhancing access to coverage and services, and integrating services for people with complex medical and social needs. This webinar, as Travis mentioned, is funded by the Robert Wood Johnson Foundation. Through the Transforming Complex Care Initiative, this is a two-year multi-site demonstration that was aimed at refining and scaling effective complex care models that address the needs of folks with complex medical, behavioral health, and social needs. As you can see on the right, we have several domains, and in the presentations today, several of these domains will be discussed, and we're looking forward to sharing all of the insights with you. So next up, I'd like to just give a little bit of information and background about today's presenters. AccessHealth Spartanburg is a nonprofit program that provides care coordination, navigation, and referral to community-based health and social service folks who are uninsured in Spartanburg, South Carolina. AccessHealth is a partnership of 10 community organizations that combine strong relationships with primary and specialty care providers with a high-quality focus on case management services for Spartanburg County's uninsured population. They have a network of volunteer physicians who work with the AccessHealth team to connect eligible patients to primary care providers, specialists, behavioral health services, and prescription assistants. We are pleased to have Carrie Rothschild and Summer Thibault from AccessHealth. Next, our other presenter, Jessica Moore, represents Petaluma Health Center, a nonprofit health center located in Petaluma, California. Petaluma runs a care coordination program that's focused on patients with multiple chronic conditions who have uncontrolled conditions, high ER utilization, and/or recent hospital inpatient stays. The patients are referred to the program by primary care providers, or they can be identified based on physician intuition and utilization data from Medicaid, Medicare, or their own electronic health record. They use a high-touch care model to deliver health education, clinical services, and other social and medical support. And Dr. Derek D'Elia, who will share his insights later in today's presentation, is the Director of Health Economics and Health Research at MedStar Health Research Institute. What impacts health? As all of you are probably aware, as illustrated in this chart, there's 4 domains: healthcare, genetics, individual behavior, social and environmental factors. And looking at this chart, you can see that despite the spending, in particular in the United States, on healthcare services, individual behavior and social and environmental factors account for a significant percentage, as well as genetics. Although healthcare is relatively only one small component that impacts it, today's webinar will focus on those factors in orange, the social and environmental factors, as well as individual behavior, featuring some of the providers today that will talk about their strategies in partnering with other community-based organizations to address these factors noted in the circle. So just a brief overview, social determinants of health is the buzz phrase now. What we did was we captured a few of the social determinant factors, such as economic stability, which includes things such as debt, medical support, income, neighborhood and physical environment, including factors such as transportation, safety and walkability, education, including literacy, language, vocational training, food, hunger, access to healthy, nutritious options, community and social context, including support systems, discrimination, community engagement, and finally, healthcare system, health coverage, provider and linguistic and cultural competency, and quality care. And these are all at the bottom related to health outcomes. So just to review a few strategies that we're seeing in our work that are aimed at addressing social determinants of health. Employing non-traditional workers, such as community health workers, who go into homes to identify hazards, connecting patients to resources and social support services outside the healthcare system. They also assist with mitigating barriers to healthcare by helping folks sign up for SNAP, Medicaid, and other assistance. And they also serve as an interpreter, a bridge between patient and healthcare systems. In addition, as our 2 presenters will talk about today, they partner with community-based organizations and social service providers. These providers have complementary skills that are outside the health system. They establish both formal as well as informal partnerships in getting the services that their patients need most. And finally, identifying and quantifying patient needs. There's a variety of screening tools, some which will be discussed today, such as Prepare, Health Leads, among others, as well as tracking patient needs over time, using various data systems to track whether or not those needs are met. These are innovations and things that many providers out in the field are using. And finally, testing the use of technology. For those folks that are in rural areas, trying to bridge the gaps in geography, using tablet technology, other resources, and inventorying resources and tracking referrals. We listed a few, but there are many others, Healthify, on Bartha being just 2. And finally, without further ado, I would like to turn it over to Carrie Rothschild and Summer Thiebel at AccessHealth Spartanburg for their presentation.
Thank you, Caitlin. We're thrilled to be here today to share some information about our program and about the care coordination that we are doing in Spartanburg, South Carolina. We really started, and you'll see on this slide, the mission of AccessHealth Spartanburg. What I want you to know, you can read the mission, but really what our focus is improving local health outcomes while at the same time reducing the cost of that are associated with caring for our uninsured. In Spartanburg County, we have a high percentage of uninsured residents, many of whom are adults and do not qualify for Medicaid or any other assistance programs. And so looking at the percentage of people who were using our emergency rooms for non-emergent conditions really led to the formation of AccessHealth. On this next slide, you'll see some of our strategies and services through the program. We screen for our program first, and to be eligible for the AccessHealth Spartanburg program, you must be a resident of Spartanburg County, uninsured, and not eligible for Medicaid or Medicare, and living at or below 150% of the federal poverty level. Once we determine you're eligible for AccessHealth Spartanburg, then we start doing other screenings to make sure to connect you to any and everything that could help improve health. So we are talking about SNAP applications or food stamps, applying for Medicaid. Some people don't know that they do qualify or their Medicaid has lapsed, and we can help them get that started back up. Prescription assistance programs, the free telephones that come for people who are eligible for SNAP, as well as many other assistance programs. During that same enrollment period, we do what we call a psychosocial needs assessment. We are, and we'll get more into that, but it is an 83-question assessment tool that helps us determine barriers to health and healthy lifestyle. We collect medical history, assign a medical home. Medical home might be one of the more than 200 physicians who partner with us and agree to see patients in their own offices. Or it might be our free medical clinic or our FQHC or our family medicine residency program. So the medical home can mean a number of different things for people. One of the other important things I think we do is serve as a bridge between primary and specialty providers. So primary care providers would say we have a percentage of our uninsured, but we have worked up to the full scope of our abilities and cannot get them in for a specialty referral. And some of the specialty physicians were assigned patients in the hospital, say for a heart attack, and then followed up outside of the hospital, but had a hard time getting the patient into primary care. AccessHealth agreed to ensure that everyone was connected to primary care first, and then we handle those specialty referrals in our office. One of the few things that we do pay for is transportation to and from medical appointments, behavioral health appointments, and for social service or some other outside the box things. If there's an employment fair, we might provide transportation to that, or we've provided transportation to somebody for vocational rehab, things of that nature. So the other two things, really looking at connecting people to behavioral health and social resources in addition to that medical home. And if we can go to the next slide, you'll see a list of our founding partners, both of our local health systems, our Department of Mental Health, Free Clinic, DHEC. One of our local colleges handles a lot of data collection and analysis for us, prescription assistance program, and our local medical society. So we had physicians in leadership at the table helping design this program. Below that, you see a little bit about our outreach and engagement. This shared leadership model we talk about is an effort to keep the hospital system from being the sole owner of patients or of our residents' health in the community. So making sure that all of these organizations that you see at the top of the slide really had the same seating at the table and were sharing leadership and responsibility for caring for people. We also have a really consistent effort to engage our local media through newspaper, TV, radio in our upstate area of South Carolina, and then really some efforts to push that attention out nationally as well. One of the things that we do with our staff, and we have a staff of 20, is ask each person on the team to participate in a work group or on a board in the community, a task force, where they are representing AccessHealth and our program out in the community, but then they are also able to bring back information that's relevant to our program and to our patients in our program. And then the idea of capitalizing on serendipity. We love this idea, and this is this is when you have a friend that you meet in the community, maybe that friend is one of your providers, you ask them to help out with your program, or knowing someone who has a certain business or service that they could help benefit our patients. It seems like we're constantly running into people and things just happen like magic that way. And so the next slide, I'm going to let's see, so we're going to talk just a little bit about some added partners. These were not founding partners, but some other unique collaborations that we've added in the years that we've been open. There's a local therapy center and teaching clinic called Emerge Family Therapy, which is the training grounds for one of our college's marriage and family counseling program. We use that to provide counseling on a very sliding scale fee for our patients. Middle Tiger Community Center is a rural community center which has opened a free clinic, and we provide all of their screening and enrollment. We have a local osteopathic medical school we call VCOM, and we are working with those providers and residents to act as case management extenders through our program and working with them on health fairs and other rural opportunities. We have some churches that we partner with free clinics and with food pantries. The Spartanburg County Detention Center is one that we've worked closely with. We go to the detention center and enroll people there before they're released who are eligible for our program. We spend a lot of time at our downtown public library. That's where we work with a lot of our homeless population. And we have some prison rehabilitation programs that we also provide enrollment for. I'm going to turn it over to Summer on this next slide to talk about more about how we address those social determinants of health.
Thank you, Carrie. So AccessHealth created our own assessment to try to capture the social determinants of health and the needs and barriers that our clients are facing. We really want to see the entire picture and offer a more holistic approach to their healthcare. So some of the topics included on this assessment are, of course, their medical history and needs, primary and specialty care, if they already have providers in those areas or if those providers are needed. We address their medications, vision and dental needs, and then behavioral health history. We assess for mental health diagnoses or needs in that area, substance abuse, or counseling. And then we get into the social aspect. We ask about housing, transportation, if they can get to their appointments that we schedule. We want to know about their education. If they are looking to get their GED, we can refer them to adult education here in Spartanburg. We assess employment, if they have access to food. And then we also ask if they are connected to a church or spiritual community, because we really want to capture every opportunity that we can to provide some additional support. We address these issues and administer this assessment at initial enrollment, and then our screening tool generates a care plan in our case management software, which generates goals specific to each client. So in the next slide, you'll see, on the next slide, yeah, there you go. You'll see basically all of the questions that we ask. Depending on how the client answers the question, it will generate drop-down boxes and even more questions. But you'll see that we ask everything from, do you eat a balanced diet, to what was the last grade you completed in school. One of the interesting things, one of the two most interesting things that we ask, are you registered to vote? We recently added that. And then we added, what are you most proud of? We felt that this would leave the interview on a more positive note and offer some hope or motivation for the client as we start transitioning into setting their personal goals. So these questions change. We reevaluate them routinely, and then we change the questions accordingly to make sure that we're addressing our clients' needs. Next slide. So once we ask the questions and we generate the care plan, we prioritize those needs. We provide information and education to our clients about how we can find the resources and obtain the resources to meet those needs. And then the care navigators will create referrals to our community partners. And then there's an ongoing relationship between the client and care navigator, which allows the care navigator to follow up on the referrals and make sure that the client is able to obtain their goals. As that relationship continues, so does the education. So from there, we have created some really unique out-of-the-box partnerships, and Carrie's going to talk to you about these on the next slide.
One of the partners that we reached out to several years ago is a local chiropractic school in our area, and we were able to address one of the main issues that we had problems with was pain management. And a lot of our physicians were not comfortable handling pain patients, and it seemed like a lot of back pain and chronic pain. And so one of the things that the chiropractors were willing to do was to start taking patients just simply for pain, of course not prescribing any medication, but this was simply something that we could offer our patients. And acupuncture we added more recently too. We have partnerships with organizations that help furnish an apartment. Sometimes we are helping people to find affordable housing, and we can get the housing, but there's no furniture. So we've secured some furniture through Corner of Hope. The City of Spartanburg helps us with free bus passes to use the city bus system. One of the things we did with our city farmers market, we knew that our community was able to take advantage of the double SNAP program, and we were letting our patients know about that so they could, their food stamp dollars could go a lot further if they used them at the farmers market. But we realized they were not going, and when we dug down a little deeper, there was a stigma to many of our patients that the farmers market was kind of an elitist place, and they were nervous to go. So we started a meet and greet program where we would meet our clients there and shop with them. The Hub Cycle program is one where people donate bicycles, and we can get bicycles to be used either for exercise or for transportation. You get 3 months and a helmet and a bike lock, and you can renew it as many times as you need to. I told you about the detention center, and then we do some other screening clinics with our Heart Resource Center, flu shots with CHEC, and we have a free little library on site here at AccessHealth. So it's you can donate books to it. It looks like a big little kiosk with a door. You open it, and there are a bunch of books inside, and so those are really popular books and magazines, and we really want to encourage literacy. Another, on the next slide, you'll see a picture of one of the partnerships that we created through the Gift in Kind program, and this is a picture of our Gift in Kind closet. So this is a partnership between the United Way, our local United Way, and an organization called Excel Logistics, and they operate a warehouse that collects items from, it's a return center from Walmart. So some of the products are Walmart products, others are from the vendors that sell their things through Walmart. And so some of these things have been damaged during shipping. Maybe there's a bottle top that's cracked on lotion, or it's last season's comforter, or an excess of face powder. So you never know what you're going to get, but we are able to, along with other nonprofits in the community, join this program for a little less than $2,000 a year we spend joining the program and paying our shopping fees. It's kind of like that supermarket madness where you've got half an hour, we schedule an appointment, we go into this warehouse with a buggy, and we've got 30 minutes to throw everything in that cart that we can. A lot of what we get is paper products, toilet paper, paper towels, toothbrushes and toothpaste, a lot of toiletry items, cleaning products, over-the-counter medications. And this is a really great program. You can see the diapers along the top, and you just think how much diapers cost, how much feminine hygiene products cost, toilet paper, and none of that is available through food stamps. So this is stuff that all of our patients need, and it does a couple of different things. We're able to provide some assistance to people by giving them an opportunity to shop in the closet, but we also, it's a great way to keep in touch with our patients. They come back to shop in the closet and we find out they've moved, or they have a new diagnosis, other things that we might not find out. And then we also use this as an incentive. So when people reach goals and milestones, we give them additional shopping privileges in the closet. That's one of the most popular parts of our program. And that is the bulk of what I had to share. Are there questions for us?
Well, Carrie, thank you so much. This is Caitlin. So we actually do have quite a few questions. The first one we'll start with is, how many patients does AccessHealth serve in a year's time?
We keep a running total of about 3,000 people in the program.
Terrific. Thank you so much. The next question we have is, you spoke about chiropractors. For those chiropractors, how are they paid?
None of our physicians are paid. None of the providers are paid. So, well, some physicians are receiving payment from their health systems as a salary, but we as a program are not reimbursing for any services like that. So this is all donated care.
So Carrie, as it relates to physicians or providers that partner, how do you go about finding these generous providers that are, you know, in some ways volunteering their time? How do you find those that are willing to help AccessHealth clients?
Sure. I think one of the most important things to start with was inviting the local medical society to the table to talk about the issue and to see what they wanted, what they thought needed to happen. And then we created a commitment form. And so what our commitment form says is that physicians can sign up to participate at whatever level they desire. They usually commit to see a certain number of patients per year, and or volunteer a certain number of times per year in the local free clinic. What it has looked like over the years, an average of 5 new patients per primary care provider and 10 new patients per specialty provider per year. The other thing I think that's important is, as we try to find new providers to participate, is it's really seems to work best peer-to-peer recruitment. So we have a couple of physician champions, we call them, on our partner group and board, who reach out to see if we can expand capacity in certain areas, particularly in specialty care where we have big needs and low resources.
Great, those are excellent tips. Always an issue with provider recruitment, really helpful. We have a question related to referrals. How do you track your referrals? And second part, what case management software do you use? We use a case management software that's called CareScope through Civic Health. And it is just a case management software, so we don't house medical records or anything like that in it. Right now we use Healthify, and they've been great to partner with. We also have 211 in our state, and so we are making those referrals through those two databases,
but we track the referrals in our case management software. So I could pull up to see how many referrals to smoking cessation or to housing we had done in the last week or month, or even how many a particular care navigator had done.
Great, thank you so much. We have a couple questions about transportation. How do you arrange for transportation? Are you using vendors? What funding sources?
We are, and what a huge problem. I wish we could say we had solved that problem. We have not. We have two, aside from the free bus passes, which are extremely helpful, but only help a limited number of people that are traveling within our small city. We use the county transportation system, which in a lot of places you would know as the Medicaid van. We pay, that's one of the few things we do pay for. We pay 79 cents a mile for that. And of course, patients have to give a 2-hour window of when they might be picked up to get to an appointment, and then call at the end of the appointment and get picked up whenever somebody can come get them. So it's very often a full day of just one doctor's appointment. It is something we spend about $3,000 a month on transportation. So that's a big expense for our program. We use cab vouchers just every once in a while when it's a kind of an urgent situation. Maybe the patient had an appointment that was more urgent and we didn't have time to schedule in that 3-day window that you have to use for the county transportation. But we're really hoping that our community will find some other opportunities for transportation.
Great, thanks so much. We have quite a few questions about funding. Could you tell folks kind of how you're funding, what it's comprised of generally, state, foundation, other sources, please?
Sure. The Duke Endowment was our primary funder in the beginning. They fund similar programs in North and South Carolina. And we have since then, and that was in 2010 when we opened, they've continued to help fund our program each year. And then we also receive United Way funding, hospital system foundation funding. Our nonprofit hospital, Spartanburg Regional, does an annual employee campaign, and they've raised about $800,000 for our program over the last 8 years. We've had funding with the Robert Wood Johnson Foundation. We have local individual funders and fundraising events. And then some of our staff are subsidized by the health system itself.
Great.
Oh, I should also mention, we do ask patients that we have generated about $30,000 a year from asking patients to consider paying $20 recertification fee. So once you're in the program, you can be in the program for a year at a time, and then you recertify. At that point is when we would ask for $20 as kind of a processing fee. Now, if you don't have it, that wouldn't keep you out of the program, but this was an opportunity to really to provide people an option to be able to contribute. And the physicians brought this up. This was their idea. They really wanted people to have some skin in the game, they said, but did not want their offices to have to try to collect money. So that $20 annual recertification fee has been significant.
Thanks for adding that. This is a question that folks are always wondering about paying for specific services. So that's really helpful, Carrie. We have another question. It's a couple parts here, so I'm going to break it down. Folks are very interested in the health assessment tool that you use. The first question is, who conducts the assessment? Is it a clinical or a lay person? And do you ever get any pushback or concerns from your clients about the length of the survey?
I'll let Summer answer that.
So every time a client comes in to enroll, they are given the assessment. We have 5 community health workers here at Access Health that generally do the enrollments. We also have 3 registered nurses on board that also do the enrollments. So those are the people who are administering the assessment most of the time. And we do get some push from clients about the length of the assessment. It's we try to let them know ahead of time that they're going to be here for a couple hours when they come in to enroll, because there's so much information to gather and so much to go over. But really, when we start asking the questions on the assessment, it just starts a conversation that lays a foundation for that relationship building. And most of the time, I find that clients actually enjoy telling their story. You know, sometimes they just want to get it off their chest, and they like having somebody there to listen to what they've got to say. So most of the time, we don't have any issues. If a client comes in and they're pressed for time, you know, we may speed through it a little faster, but I find that clients typically enjoy being able to tell us their story.
Thanks so much, Summer. We have a question as it relates to the questions. Do the 83 questions in some way, shape, or form auto-populate into the care plan?
They do, yeah. And that generates the goals that we go over with our clients and to set their goals.
Great, thank you. 2 more questions. Does the software system that the assessment uses have any predictive capabilities?
I don't think so. Not that I'm aware of. Maybe it will in the future. Maybe I'll predict that it will.
Great, thanks for the honest answer. And last one related to the assessment. How do you adapt it for non-English speaking clients?
We have 2 bilingual Spanish-speaking eligibility specialists here on site at Access Health. We also have the language line through our healthcare system. So, you know, if somebody speaks any languages other than English or Spanish, we can call the interpreter through the language line.
Great, thank you so much. Okay, we have 2 questions related to evaluation. How are you measuring impact? Or no, first is, are you measuring impact? And if so, how?
Sure. So yes, we are, and we do that in a number of ways. One of the biggest ways right now is looking at hospital utilization and changes in utilization. We work with our state revenue and fiscal affairs office to collect data 12 months pre-enrollment in the program, and then compare it to 12 months post-enrollment in our program. And we're looking at those ambulatory conditions or things that could have been seen in the primary care office or could have been prevented had people had access to care. We're not looking at changes for anything other than those ambulatory conditions, but we see really significant progress and reductions in utilization for diabetes and CHF and COPD, asthma, a number of things that are pretty expensive and pretty critical. And then we also see changes in utilization for things like UTI and ENT issues, which is also maybe less expensive, but still is a significant sign that things are moving in the right way and people have access to the care that they need. One of the other things that we look at with the local healthcare system, Spartanburg Regional, is charity care and the reduction in charity care. And so when the program opened, the year before the program opened, Spartanburg Regional wrote off $116 million to charity care. And this past fiscal year 18, it was down to $54 million. Now, certainly, I wish we could say that was all Access Health. It's not, but I think it really goes to show that funding programs that are helping people get the care at the right place at the right time are important. Some of those care transitions programs, the prescription assistance program, AccessHealth, things like that are really helping drive down those charity care costs.
Thanks so much. Great insights there. So we have a question, a two-part, as it relates to training. Do you train? Can you talk a little bit about your training for your staff? Do you use techniques such as motivational interviewing or other engagement strategies? And what are your strategies for engaging hard-to-reach members?
Yes, so motivational interviewing is something that all of our staff have attended, and it is one of the things that everybody, if they start to work with AccessHealth, must go through. We do the motivational interviewing, we do SBIRT, screening, brief intervention and referral to treatment training. We're doing some ACEs training and trauma-informed care training with our staff members, mental health first aid, and then we make sure that everyone gets to go through a poverty simulation. So we do a lot of training with our staff, and we do a lot of ongoing training. So some of those skills that are learned in motivational interviewing are certainly useful in working with hard-to-reach patients. I think part of what, one of the other things that we do here, I would say, is not so much a technique as it is a culture. We had a client that told us that everybody in our office was professionalism infused with compassion. And that's what we loved that, and we've really tried to make that even more seen and felt when you come into our office. We do have a number of nurses on staff and a social worker, and the staff here are all leased from the health system. So technically they're health system employees, but we don't wear those badges. Our nurses don't wear the white vests. We try to be very approachable. And we do some role play with each other and with trainers in our community, communication role play. And then pulling in others as needed. Sometimes one client or patient, we use those terms interchangeably, might do better with another staff member. So sometimes we use that.
Great, thank you so much. We have time, ladies, for one more question, then a breather for you all. You've been great sports today with taking all these questions. Folks are really interested in the VCOM partnership. Could you talk a little bit more about your partnership with VCOM and the types of activities or things that you work on with their team?
Sure, and I wish I could talk for an hour about how fantastic they are. We're really, really lucky that they are in our community. One of the partnerships we've had with them was with a group of students that were interested in providing ongoing education for patients who had been diagnosed with a chronic condition. And they came up with this idea called the other 45, there's a 15-minute appointment with a physician or nurse practitioner, and then they were going to take the role of filling that other 45 minutes with support, education, and making sure that people got what they needed. So we have rolled that out in partnership with them over the years at 2 of the free clinics that we use. We do that at the FQHC, and then they do some one-on-one things with patients too at health fairs in the community or at the monthly fairs at churches. The program that they're working on with us right now started as a pilot a year ago, a 90-day pilot, I guess it was, where we paired some of their medical students with some of our care navigators to provide extended case management. And what I mean by that is after hours, our staff are 9 to 5, Monday through Friday. And there are some patients that really needed somebody in the evening or on the weekends to touch base with them, or were hard to reach, or needed simply more support than one person could give them that was carrying a large caseload. So the medical students worked with our care navigators in a team of 3 medical students to 1 care navigator, and made sure to contact patients either by phone or in person once a week. And it was so successful in that we all enjoyed it. We had not started really evaluating outcomes from it yet, but the school went ahead and asked us to continue that as a standard program with them. So that started in January. And so we'll keep you posted. Hopefully you'll see more about that as we are able to gather some data and see if we are improving some of those health metrics. We're going to be looking at A1C levels, blood pressure, BMI, and adherence to care plan, things like that going forward.
Great. Carrie and Summer, thank you so much for the terrific presentation and fielding all those questions.
Thank you.
Next up, I'd like to introduce Jessica Moore, Associate Clinical Director and Director of Innovations at Petaluma Health Center. Jessica?
Hi, thanks so much for having me. So I'm just going to give you a quick overview of who we are at Petaluma Health Center. Different from the group that we just heard from, we are a federally qualified health center in southern Sonoma County. We have two main sites. The first was in Petaluma, and then 3 years ago we opened a second site in Rohnert Park. We also have a small site within a homeless shelter here in town and a couple of smaller school-based sites. We use eClinicalWorks as our electronic health record, and we have about 30,000 unique patients. 50% of our population has Medi-Cal, about 15% Medicare, and about 40% of our population is monolingual Spanish speaking. So when we're thinking about screening for social determinants of health, we looked around at the different tools available, and we settled on using the Peertopeer tool, which I'm going to go into a little bit more later. So just kind of initial observations from our health center perspective. We've known for a long time that the social determinants of health have a significant impact on patients' health, as you heard at the top of the presentation here. And addressing these social determinants can have a significant positive impact on patients' health outcomes. But we can't help if we don't know what those needs are. And we really weren't screening in any standardized way. And we also really were keenly aware, in a health center population where our patients are complex and there are a lot of pressures on time and resources, that it was going to take an initial investment of time to really address these additional needs in a meaningful way. And so, lots of questions about how are we actually going to do this in a sustainable way. So looking at the problem, community resource information was not widely available to our staff at the health center locations or to patients. So there are lots of great community organizations in our area that are addressing some of these needs, but it wasn't really clear who they were and how to get connected to them. As I mentioned earlier, we weren't really doing any standard screening. We were sort of waiting for it to come up organically that patients had a specific need, but we weren't really asking the questions in any standard way. And then both providers and staff had really a fear of being overwhelmed by what we might find if we started asking these questions, right? So we already have a lot on our plate trying to address these complex medical needs, but what if we start asking about all of these social needs? What are we going to find, and how are we going to address those within a resource-constrained environment? So we started looking for solutions, and we settled on a web-based platform. So kind of transitioning from the idea of this, like a physical binder, like we did have a resource binder, but it was not always up to date. It wasn't available, to every staff member. Everybody didn't know how to find the resources. And it wasn't updated, so it wasn't always as useful as it could have been. So we transitioned into a pilot with an organization called Purple Binder. which is one of these web-based platforms that connects social and community resources with patients and providers. So we entered into a 12-month pilot with them to see how that would work with our population. After that pilot, we ended up, Purple Finder was actually acquired by Healthify, and so we were faced with renegotiating our contract, and by that time there were several other platforms out there. So we did a full assessment, not only our health center, but by that time we had engaged our regional coalition of health centers and decided that it really made sense for us to look at this not just at an individual health center level, but at a regional level. And so together we looked at several of these different platforms and settled on Aunt Bertha. So we are in the process of transitioning within the next month to use Aunt Bertha. So what does the screening look like? When we first started our Purple Binder pilot, we anticipated that we were going to find all of these patients that had a lot of needs, and we were going to use this resource, and it's going to be fantastic. And when we rolled it out with our first team, after the first week or two, we kind of got back together with our project team. We said, okay, how's it going? This is our utilization rate. It looks like we're not using it that much. Like, what's going on? And we realized that we just weren't asking the questions. And so, if you don't ask, then you don't know what people need, and you're not using the resource to really connect people in the way that would be helpful to them. So if you're not familiar with Prepare, it's the social determinants of health screening tool that NAC really was instrumental in putting together. So the protocol for responding to and addressing patients' assets, risks, and experiences. I can never remember what that stands for, but it's on the slide there so you can see it. It really goes into 14 core social determinants of health domains. So you can see the core domains here at the bottom. Several of them are UDS domains, so race, ethnicity, veteran status, farm worker, English proficiency, income, insurance, neighborhood, housing. And then the non-UDS domains include education, employment, security, social integration, and stress. In addition to those core measures, you'll see at the bottom some optional measures, including incarceration history, transportation, refugee status, country of origin, safety, and domestic violence. And so when we looked at this for our population to determine which of these optional measures we were going to include, we took it to our Patient and Family Advisory Council, which I strongly recommend, if you don't have a council set up, at least really getting input from your population, because it came out really strongly that our patients, they were fine being asked about domestic violence, transportation, safety, but they really did not feel like the questions regarding incarceration history, refugee status, or country of origin, they were comfortable answering sort of in the current climate. So we took that to heart and did not include those. Then it was time to kind of set up our screening strategy. So initially we were very ambitious, and we thought, okay, we're just going to screen everybody, at least once a year when they come in. And our staff quickly said, that's too much. We can't screen everybody. It takes too much time. And so we scaled back and said, okay, who are the kind of key populations that we want to be sure and screen, and how can we ensure that that happens? So we embedded it in our clinical decision support. So we use a data analytics tool called Relevant, and you can see on the left here, this is sort of what those care gaps look like. So when I arrive for my clinic shift, I'm reviewing my schedule with the medical assistant I work with, and we're looking at the care gaps for each of our patients. So it may come up that they're due for colorectal cancer screening, they're due for a mammogram. We added some criteria that would trigger a care gap that they were due for prepare screening. So initially we said anybody that has a risk score of 3 or greater needs to be screened with prepare. And then we expanded that to if they have a diagnosis of diabetes or depression, regardless of their risk score, that's who we want to screen with prepare. And so we've rolled this out over the last 16 months now, and we have screened 16% of our adult population for social determinants of health. So once you start to collect data, then you really can see like where is the need and what kind of partnerships do we need to really solidify and bring into our health center, more than just referring them out in some cases. So when we looked at the initial data that we had from Purple Binder in terms of where we were trying to send people and the prepare tool with people's responses, we noticed that the top 2 things were food insecurity and employment. The third was housing. So we were able to start looking at, in the community, what are our options for addressing these 2 key social determinants of health, and who are the people currently working on these issues, and how can we partner with them? So in terms of food, we were fortunate in our area. There's a local farm, nonprofit, that is really dedicated to improving food security in our community. And we had worked with them on a couple of other projects in the past, but invited them to come and actually be in the health center 1 day a week, just set up their farm stand. They take SNAP, and they do double bucks for food assistance. So once a week they come in, instead of patients having to go to the farmer's market. So you heard the previous presenter saying that sometimes there's some stigma, or patients maybe didn't feel comfortable. So we eliminate that by really bringing them in-house, so they're right here and can help provide healthy, fresh, local food at low cost to our patients, and that's been really successful. The second partnership related to food that we were able to establish was with our local food bank. So both at our Rohnert Park site and our Petaluma site, we are a pickup location for food boxes once a week, every week, on a different day than Petaluma Bounty is here. And we worked with them to say, these are the kinds of foods that we don't want to have from the food bank when you come to our location. We can't say that they will always have the things that we want, but they did really work with us, because we felt like it was important for us as a health center to not be promoting, highly processed foods, and, for our diabetics, especially, like things that are really high in carbohydrates. So they really were great to work with us to set up something that would work for our population in our setting. And so 2 days a week, we have some food resource in our health centers, which is really great. The second need that I mentioned that we identified was really employment and job skills. So Sonoma County JobLink is part of the Workforce Investment Board, and they have a physical location in Santa Rosa, which is about 25 miles away. Our health navigators were sort of aware that JobLink existed, but really weren't aware of what services they provided. And also, it was difficult for our patients without transportation to get there. Even though it's not that far away, there's no great public transportation option to get there. So it was taking people almost 2 hours to get there on public transportation, and that was a real barrier. So we engaged them in a conversation, said, look, we know that we have patients that are unemployed and really could use some support with that. Tell us about the services that you offer. How can we get our patients more closely connected with you? And they were more than willing to have that conversation. We learned about some things that they offer virtually that our navigators could set them up with. And then we also are in the process of developing some partnership around transportation. So we currently have a partnership with Lyft where we get our patients rides to medical appointments using Lyft. And so the county and JobLink said, you already have this partnership set up. If we have clients that need transportation to JobLink, can you guys use your Lyft account and we will reimburse you for those rides after these clients have met eligibility criteria, and we know that they are going to come here to get more services. So that was really exciting. And again, we wouldn't have known that that was even a possibility if we hadn't just started the conversation. Petaluma Adult School also offers classes, and things from ESL, computer classes. They're really an excellent resource in the community for free or low cost courses, and also provide childcare to clients who need it. So that was also really excellent for our navigators to learn about, and then be able to connect patients more closely with these courses. So when enrollment is open, they're able to get patients enrolled. Petaluma Adult School come to our patient and family advisory council meetings to really spread this knowledge throughout the community. So that's another exciting partnership that we're working on. So in terms of lessons learned over the course of this work, you really don't know until you ask. And this goes for not only screening patients, but as well as these partnerships. So like I mentioned with JobLink, we never thought that they would have funding available for a transportation program to get our patients them, but it turns out they did, and they were more than happy to start that program. So that was really exciting. And as with everything, it's very important for frontline staff who are doing this work to be at the table from the beginning. So involving our navigators, getting them out to visit these places that they're going to be referring clients to, so that they have a real understanding of what they're sending people to, and getting them connected in more meaningful ways. And then leadership, obviously, if the leadership is really engaged and committed to this work, you're going to be able to move forward faster. And really evaluating as you move forward, what are our priorities? Do they align with, how do they align with what's going on in the community? And having this data from Prepare and from our Purple Binder pilot that really showed kind of what resources we were trying to send people to, gave us great information to launch these partnerships. We also have learned that there's a lot of energy around these ideas, and so often there are opportunities for pilots or seed funding if you really start looking for it. At least to kind of get you started. And the partnerships that you build do take time and energy, and they have to be maintained if they're going to be successful. It's really great community building work, and getting outside of our clinics, understanding that we don't have the resources or expertise to really address all of these needs internally. So really finding out, where does it make sense for us to partner, and what kind of community organizations is it really worthwhile to bring in-house? Do we have the space? What do we have to offer? And forming these partnerships that are beneficial to the community partners, to patients, and to the health center. So because we know when these needs are addressed, they not only improve health outcomes, it's also, significantly more rewarding for providers and staff. So that has been a great benefit of this work as well. So I believe that is all of my slide, and I'm happy to take questions. I think Derek has something to say first.
This is Caitlin. Thank you so much, Jessica, for that excellent presentation. We do have a number of questions, so folks, we will get to your questions. But first, what we're going to do is we are going to shift gears to Dr. Derek D'Elia, who will share some reaction to both presentations, as well as some of his insights from evaluating these programs. Dr. D'Elia?
Okay, thank you, Caitlin. And I know we're short on time, so I'll try to move quickly so we can get to everyone's questions. So I just prepared a few thoughts about the implications of all the work that we heard about at AccessHealth and Petaluma Health Center. So the first is that the discussion today is really relevant to a lot of what's going on with regard to healthcare payment and delivery reform in Medicare, Medicaid, private insurance. There's a great deal of interest in moving away from fee-for-service payment and really directing the financing and delivery of care more towards population health kinds of things, working with accountable care organizations, bundled payments, and lots of other ideas. And, the theory is that you put these payment systems in place and healthcare providers will figure out a way to respond and respond well. But at the ground level, you need tools to do these sorts of things. And, given what we know about the social determinants and their impact on population health and costs of care, having these tools in place that we heard about today really, falls in line with what lots of people are trying to do in the health system. And it's worth pointing out that clinicians, doctors in particular, are typically not well positioned to do this kind of work, simply because as we're learning in our evaluation of complex care programs and other research, patients are often not comfortable talking to their doctors about these issues, and even if they were, clinicians don't have a whole lot of time to do even more work in the space of a short office visit. So having these kinds of tools is really essential, and if you can connect them to your electronic health record, then it becomes even more powerful because they'll be the information will be there for clinicians to develop care plans for their patients. The second point I wanted to make was about social determinants of health and what economists often call the health-wealth gradient, which I think is an idea that's often underappreciated. We often talk about how low income, low wealth can lead to poor health outcomes. Lots of people understand that. But it's really a two-way relationship because oftentimes if someone is in poor health, if they've acquired a disability or they have an accumulation of lots of chronic health problems, that tends to lead to lower income and often lower wealth accumulation, largely through reductions in labor supply. When people are really sick, they will work fewer hours, they may drop out of the labor force, or they might change jobs, switch to a lower paying job that's just more accommodating to the health issues that they have. And so the kinds of data collection tools we've been hearing about today around social determinants of health, I think they can be really useful as kind of early warning signs to let clinicians know about patients who might be falling into an economic situation, or rather a health situation that's going to affect their finances. And these things tend to reinforce each other, either in a good direction or in a bad direction. So understanding, the two-way relationship, I think, is really useful and important to really understand what's happening with patients and what kind of interventions might be needed to make sure that they don't fall too far along either dimension. Also, the tools that were discussed today, I think, really have implications for how we match the supply and the demand for community resources. So the way it was discussed today is really there are all sorts of not-for-profit organizations that are offering services around food banks or housing or employment or other things like that. That's all the supply of services. But what we're doing with all this data collection is learning more about the demand for services to really understand what should be supplied in the first place. So the demand is really about what is it that people need, what are they aware of, and what are they willing and able to use. And really the willingness and ability to use anything often comes down to the price that people have to pay. But these community resources, typically they'll be available for free or on a sliding scale. But there are other barriers that could get in the way that we can certainly learn about in working with patients. Barriers like location, is the place hard to get to, or do people need transportation, hours of operation. Both Carrie and Jessica mentioned the issue of stigma, which might be an issue, and that's something that I think health systems are going to learn as they partner with patients and community providers to try and understand what's available, what's really needed, what kind of barriers are there to using these services. And ultimately, I think this is a way for health systems to inform the work of social service providers as much as social service providers are going to help the health system achieve their utilization and cost of care and health goals. And the final point I wanted to make is about how all this work really challenges us to redefine what are the boundaries of the health system. And I think Jessica alluded to this a little bit at the beginning of her presentation, in the sense that if you're going to address the social determinants of health, you're going to get into all kinds of new lines of business: housing, employment, nutrition, lots of other things. And certainly healthcare providers can't fix all these problems. But what healthcare providers can do is identify what the needs are, connect people to services, try to ensure a smooth handoff, maybe do some follow-up to make sure people are able to use the services that are available to them. But this can quickly become very overwhelming, and I think this is really one of the frontiers of health systems management, is really understanding what our patients' needs across all these different dimensions that affect population health, and what is it the health system is able to do to facilitate what patients need without taking on too much and trying to solve all the problems on their own. So I think I'll leave it at that and turn it back to Caitlin.
Great. Thank you so much, Derek. We appreciate your insights and reactions there. Thank you, folks, for all your questions. We're going to delve into some, and I just want to say your questions can be related to Dr. D'Elia's points, Petaluma's presentation, or AccessHealth, but I'll start with a bunch of Petaluma questions. So, Jessica, folks have a lot of questions as it relates to your budget and your costs for your social determinants work. Can you give a sense of, I mean, this is a very nitty-gritty question, but generally how you're paying for your social determinants work? Do you have partnerships? Well, we know you have partnerships with community organizations, but are you paying them? How are you reimbursing them for some of the social supports and services that they provide to your clients?
Sure. So in terms of like the partnerships that we have with other organizations, we're not paying them for any of the services. We are just really helping their services to be more utilized. They all have their own kind of funding streams. And so, oftentimes when they have more, I guess in some cases, us giving them more clients allows them to actually get more funding from their funders. So we don't have any financial relationships with the community-based organizations that we are referring to. Kind of the thing that we're able to give them is space in our organization, and so they don't pay for that space, when they come in and use it. So that's kind of how that works. We were fortunate to get a grant to help launch some of these activities, just a one-year grant, and that was a $60,000 grant that really helped us to kind of build some infrastructure and do training and help to just to set up these partnerships, just because it does take time to kind of communicate and contract and figure out what's going to work. So that was some of the startup costs, I would say. And a lot of that was really staff time. And then in terms of ongoing, I mentioned the Purple Binder pilot. So that was also, they were a startup company at the time. And so the pilot was very, very inexpensive, except for kind of the staff time that we used to do it. But then when we looked at kind of the contract negotiations to finalize a ongoing contract after they were acquired by Healthify, that was one of the key things that we were looking at was, you know, everybody has a different price point for these services too. And so that's also when we decided that, you know, working with at a consortia level made more sense than just working at a health center level to get a service like Aunt Bertha or Healthify. And so the cost for that ongoing, it's negotiated through our regional consortia. And if you were doing that on your own as a health center, you know, again, I think they all have different pricing structures. It kind of depends on like how many clients you have or how large your service area is, and if they already have something set up for your area or not. But it's like in the ballpark of like $1,000 a month, I would say, for a larger organization. And so ongoing, we're just using, like we're dedicating some of our operating expenses to do this work because we think that it will make a significant impact in the outcomes and efficiency also for our staff.
Great, thank you so much. We have a lot of questions about the assessment that you're using, Prepare. Who conducts the assessment? What staff and what are their credentials?
So patients get the Prepare form. It's a paper screening, and the medical assistant gives it to them at the time of rooming. The patient fills it out. The medical assistant actually enters the data into our electronic health record and initiates referrals. Either the medical assistant or the nurse or provider, sort of like whoever sees that form first, can initiate the referrals for any needed services. It's primarily the medical assistants that are doing it though.
Great, thank you so much. Very specific question as it relates to Prepare. This question says, disabilities not mentioned in the list for Prepare Uniform Data System or non-UDS. How would a disability change the strategy for the client/enrollee?
So, you know, I guess it would really depend on what the disability was. I'm not sure quite how to answer that.
No worries there.
Sorry.
You're taking an honest stab at it, and we can certainly follow up on our end with some of the folks that we know that kind of specialize in this.
Sure.
We have a question related to the Healthify tool. Do the CPOs you refer to have access to it? And how do they update you in terms of when they connect a patient to resources for that closed loop referral?
Yeah, so all of these different platforms, they have an option for your community-based organization to sort of opt in to being part of a more closed loop system. At baseline, everyone is just sort of there as a directory so that I can text, email, or print that community organization's information and give it to the client that I'm seeing. But if the community-based organization kind of opts in to be a referral partner, then they get access to the tool also and can, you know, communicate with us to say, yes, I saw this patient, or no, they never showed up, or we tried to reach them. So there are kind of options for how you want to set that up. And I would say one learning for us is that you really want to be thoughtful about who what kind of organizations you want to set up a closed loop referral system for, because I don't know about other providers on the call, but for us, we have a hard time closing the loop on all of our medical referrals that go out, right? And so really taking a step back and thinking, okay, like how, for who, for what kind of patient, and when, and what kind of referral partner do we really need to know that like that was closed and done, or like how can we leverage the patient participation in reporting, or you know, to know when that happened, or like in what cases do we just let them, you know, make the connection and trust that, you know, we've done everything that we can to make sure that that's a seamless connection. You have all the information that you need, and now you're going to decide if this is something that is, you know, important enough to you to follow through with.
Great insights. Thank you for that. We have a question as it relates to Aunt Bertha. What were the primary decision factors when you chose Aunt Bertha, and what do you see are the benefits now that you've been using it for a while?
So a couple of the really important things to us were we wanted a platform that had a patient-facing application, a web-based patient-facing application. So some of the tools are really just for providers and community organizations, and they don't have a way for patients to interact with it like on their own in the community. And so that was one thing for us. The other piece, another important piece, was cost. And Aunt Bertha did well on the cost piece. We also talked to other organizations who were using some of these different platforms and got really great reviews for Aunt Bertha, that they were, you know, they were easy to work with. They did a great job of updating the information. The interface and single sign-on was, you know, easy to work with. So those were some of the things that led us in that direction. So we had been using, like I said, Purple Binder, and Aunt Bertha, we're just doing our training. We have not implemented it yet. We're implementing it next month.
Great, thank you so much. We have a question as it relates to your data and analytics tool, Relevant. Can you speak to your tool and how it assesses the risk of your population?
Sure. So we actually we built the risk assessment based on some AAFP risk stratification criteria. So and then we told Relevant what our criteria was, and so then they're able to take that criteria and give the patients a risk score. So, you know, based on number of medications, recent or hospital utilization, based on substance abuse, mental health diagnoses, like all there are, you know, several criteria that give you a point or half a point. Chronic disease, number of chronic diseases. So we kind of developed our own criteria for the risk stratification, gave that information to the analytics tool so that it could pull out that information from our EHR and give us a risk score for all of our patients.
Great, thank you so much. Shifting gears a little bit to training your staff. Given that patients with complex needs are often at higher risk for trauma and interpartner violence, what type of training do you provide your staff, and how do you support them when they're asking these questions and someone has, you know, a difficult experience, you know, either personally or in dealing with the situation with the client?
Sure. So we are doing some trauma-informed care training for all of our staff. But just to be clear, the staff is not asking the patients the question. It's actually just a paper questionnaire, and the patients are answering the questions. There's been evidence to suggest that, you know, when patients get this on the paper form, they're more likely to be honest about it than if they're asked verbally. And so when the medical assistant gets that information on the paper, we have sort of clear guidelines to, if they answered positive to intimate partner violence, we have behavioral health staff on the team, integrated on the team, and they're the point of contact for that client. So, so that medical assistants aren't, getting a lot of story and information that they're not equipped to deal with. So, in addition to just the trauma-informed care training, then they know kind of who their resource is on the team to really help patients with these issues that are beyond what their training would allow them to do.
Great, thank you so much. We have time for one final question, which is, what have you found are the differences between providing social services in the clinic versus referring patients out to other locations or community-based organizations?
In our limited experience, anytime that we're able to provide something in the health center, our patients are more likely to use it. They know us, they trust us, and so when we're able to sort of confer that trust on another organization because they're in our four walls, it's just gone a lot better in general. It's hard to get people to go somewhere else that they've never been, that they're not familiar with. So, just the piece of going to another location can be challenging. And so as much as we're able to, we like to bring things in-house, at least for kind of an initial, community day or something. And so people maybe meet somebody, and then when they meet somebody from that organization here, then they're more comfortable. Okay, I'm going to go and see you at some other location because now I know you and I trust you.
Great. Thank you so much, Jessica. And I just want to say a huge thank you to all of our presenters today. This may be a record for the number of questions we've received. We really appreciate your insights and expertise. So there's two relevant resources here that I want to draw your attention to. We had many, many questions about these assessment tools that were referenced today. That first link to that brief, all of the assessment tools that are used across the 6 transforming complex care sites are available. They're hyperlinked. And then we have a profile for AccessHealth Spartanburg where you can read more about the great work that they're doing. And finally, you will rather receive an email with a survey. We'd really like your feedback on how we can improve things and what you liked and what you didn't like. So please help us by filling that out. And then within the next 2 days, you will receive some additional information, including the recording of this webinar. Thank you so much for your time today, and take care. Goodbye.